research backgrounds, their practice backgrounds, to help all of us understand better what the challenges that we face with COVID-19 and what the solutions may be, what practices we can engage in that would minimize or mitigate the risk of infection, of contracting, and the potential that we can be carriers, spreaders of the COVID-19 pandemic. Pleased to have co-hosting with me my colleague, managing editor of Insight News, Harry Colbert Jr. Harry, good morning. How are you?
Good morning. I'm doing well. Thank you so much.
Let me introduce who's on the panel today. Dr. Inel Rosario, who's in a private practice ENT business here in Twin Cities, and who is kind of the brainstorm and the organizer of this session. So Dr. Inel, good morning, and thank you so much for being here. And today we have the pleasure of connecting with another Rosario, Santano, Dr. Santano Rosario, who's a native of Minnesota, your son, and who is practicing or in a residency, I think it is, at UCLA in California. Dr. Rosario, thank you again for being here. Also, Dr. Andrew Kiragu. Have I said that properly? The right emphasis or the right, is it Kiragu or Kiragu?
Oh, yes, perfect.
Okay, great, excellent. And joining us again, thank you for being here. We so much enjoyed your presentations in recent editions of this. And Adrienne Thornton, who is a nurse and a leader in healthcare focused on children and prevention. Thank all of you for being here. Harry, start us off as you often do with kind of the background. What are the numbers right now in Minnesota?
Okay. So the most recent numbers that we have in Minnesota to date, we have 5,730 confirmed cases. Of that, unfortunately, 371 individuals have lost their lives due to the coronavirus. In terms of understanding ethnicity, right now, about 14% of all confirmed cases are categorized as Black, and that comes out to 826 individuals. And once again, in Minnesota, the Black population is around 6%. So we've more than doubled our population in terms of number of cases. So we're unfortunately overperforming there. The white population is experiencing 43%, and this is the kind of big number because this is kind of where I guess the proof is in the pudding here. 26% is still unknown. That's about almost 1,500 cases where, for whatever reason, they're not able to offer ethnicity. So that can shake out the numbers a lot once we find that out. Here in Hennepin County, which is the most populous county in the state, looking at 1,829 cases just in Hennepin County alone, far outweighing any other place. The closest to it is Nobles County, and that's where the pork processing plant is down in Worthington. And they've got, again, 866 cases. And then in Ramsey County, they're at 405.
Okay, thank you. Let me go first to Adrienne. I mentioned that she's been a registered nurse. I'll tell you, she's a registered nurse in Children's Minnesota, has been there for over 20 years, with 16 years there being in infection prevention, being an infection preventionist. She has been instrumental in establishing Children as an award-winning organization in the field of infection prevention, and she's also played a key role in assisting with the management of multiple disease outbreaks, including measles, Ebola, and H1N1 influenza. Adrienne Thornton, again, thank you so much for being here. And as from the lens of your practice, what should our community be thinking about, be learning about, and be doing to both protect and prevent, mitigate the spread of coronavirus?
So the best thing our community can do is listen and do. And so when I say listen and do, listen to what the experts are saying, and then do what they're telling you to do. And so we have a little bit of a disconnect because what people are seeing on social media and sometimes on the TV is a little different from what the CDC is recommending.
For instance, what do you mean? Show me exactly where the differences are.
So, for instance, on social media, I have seen several posts of people having parties in Chicago just this weekend.
Mhm.
I saw pictures of people in Atlanta standing in line to get their nails done because the nail shop opened and nobody had on masks. They weren't 6 feet apart. And then, of course, the most recent incident in Minnesota was when Vice President Pence came and went to Mayo, and everyone around him was masked and he was not. And so, even though the CDC issued guidance several weeks ago saying that everyone should have on a cloth mask when they're in public, and then if you're in a healthcare setting, of course, everyone in Minnesota has gone to universal masking. We're still seeing something different on the TV and in social media. And so it's really hard to get people to be compliant with the national recommendations when what they're seeing on TV and on social media is very different. And we know that when they had the voting in Wisconsin, they did have some new cases of coronavirus as a result of people standing in line and waiting to vote in the primary. And so we know that if people are together and they are not wearing the appropriate PPE, coronavirus will spread. We know that a large subset of the population has coronavirus, but they are asymptomatic. And so you can feel well and still have it and still spread it, which is why it's so important that when you leave your house, you should always have some type of mask in your hand. I don't care if you take a scarf and wrap it around your face, or if you purchase a mask from a friend, but you should have something that covers your mouth to protect you and the person that you come in contact with. And unfortunately, what I'm seeing is that people are not adhering to this. And so we can expect to see the numbers continue to go up. People will continue to get sick. People will continue to die until we start doing what the CDC is recommending.
If I go out into my backyard to garden, for example, it's me along with my pots, flower pots, or whatever, do I need to wear a mask then? Or is the question of a mask when I know I'm going to be in proximity to other people?
Right. So when you're outside and just around your vicinity, you don't need a mask. For instance, I take my dog out for a run every morning at 6 in the morning and then again at 12. And I don't wear a mask, but what I do is if I'm on the sidewalk and I see someone else coming across the street and get on the other sidewalk.
Okay.
And so the importance is making sure that you are not in proximity to anyone who doesn't live with you. You know, I don't wear masks in the house with my kids. If we get in the car and go get groceries, I don't wear a mask in the car with them. But before we get out of the car, all three of us put on our mask so that we're not exposing anyone and no one is exposing us as well. So you kind of have to think of people. People are the problem. And so as long as you're not around people, you don't need a mask. But if you're going to be around people, you need a mask.
I'm Al McFarland. This is Conversations with Al McFarland, our Friday session on social media. We're calling it Serving the Underserved. We're pleased to have members, leaders in the Minnesota Association of Black Physicians talking about COVID-19. And that was the voice of Adrienne Thornton, who is a registered nurse at Children's Minnesota. You know, you've worked, Adrienne, on, as I said, measles infections, Ebola, H1N1, influenza. Put this in context in terms of your personal experience as a frontline caregiver and who studied and worked in this arena. How does this look and feel to you? And how should we be valuing your experience, your knowledge?
So it's very different. I learned about measles and influenza and a little bit about Ebola many, many years ago when I was in nursing school, about 30 years ago. So we've known about these diseases. We have treatments for them. We have vaccines for measles and for influenza. And so we can prevent measles and influenza. And we know how to prevent Ebola. We don't have a vaccine in the US yet, but we know about these diseases. We've experienced them. We know how to treat them. We know how to prevent them. With coronavirus, we don't know anything. We are still learning. And the problem with that is it's going to continue to spread and cause illness in individuals until we can figure out, one, how to prevent it, and two, how to treat it. Right now, we just treat the person's symptoms. We don't have a designated medication that we can treat individuals with to make them feel better or get better or cure them. We don't have a vaccine that we can give people that will prevent them from getting it if they're exposed to it. And so that is my biggest fear, is the unknown. And to kind of put it in perspective, if you look at influenza compared to coronavirus, so in 2018, 2019, for the influenza season, we had about 35 million cases of influenza. And that surveillance is over an 8-month period. For coronavirus, we have already hit 1 million, and surveillance really just started in whole in March. So you can't calculate it and say, oh, well, it's only 1 million a month, and in 8 months we'll only have 8 million, because that's not the way viruses function. They continue to grow and multiply and multiply. And so what we know about coronavirus is that if I have it and I spread it to someone, I have the potential to spread it to 2 or 3 other people. So that means that as it duplicates among people, we're not going to have another million in another month. We may have another 1.5 million, another 2 million. And so that is the greatest fear with it, is that we don't know how to stop it.
And then also with that, those numbers don't take into account the efforts that have already been put in place, the social distancing efforts, things of that nature.
Right. Well, and the other part of it too is, like I said, the data started being compiled in March, and states will eventually start doing a retrospective look back to January to see if there are any cases that they missed, because we're fairly certain that it was here maybe late December and we didn't know about it. And so there are several hundreds of thousands of people who have already had it and we don't know about it. There may have been people that died between January and March of coronavirus, but we didn't know because we didn't know about coronavirus. And so those numbers are going to go up as states start to retrospectively look at their data, look at their patients, and try and compile those numbers.
I'm Alan McFarland. This is Conversations with Alan McFarland. The topic today is our health, serving the underserved. Dr. Kiragu, Dr. Andrew W. Kiragu, is a physician, medical director of the Pediatric Intensive Care Unit at Hennepin Healthcare. He's also an associate of the Children's Respiratory and Critical Care Specialist Group. They provide pediatric critical care at Children's of Minnesota. He's passionate as an advocate for children. He's the immediate past president of the Minnesota chapter of the American Academy of Pediatrics and a past president of the Minnesota Association of Black Physicians. He's also an associate professor of pediatrics at the University of Minnesota. So, Dr. Kiragu, thank you again for being here. Jump in the conversation. And my goal is simply to expand and to create an awareness in our listeners and viewers. And to the listeners and viewers, if you have questions, comments, we can monitor those, send them to us on Facebook or on YouTube. We want you to like this program and also share it. In fact, you could start a watch party right now and connect with all of your networks so that people can be involved in this, what we call robust conversation. So Dr. Kiragu, what's top of mind right now for you?
I continue to be really concerned about how our community is affected by this illness. I really appreciate what Ms. Thornton said about how in some cases, members of our community have not necessarily taken this illness as seriously as they should, whether it's house parties in Chicago or the exposures where businesses have opened. I'm also concerned in some ways how our community is also unfairly targeted. So if you think about the president's recent executive order to keep meat packing plants open, a lot of people who work in those types of industries are people of color. They're black and brown people. And when the government has really not used that power to increase PPE availability, to increase the testing capabilities, to increase a lot of other things that we need to fight this illness. We are having a situation where people are being literally placed in harm's way, where they have to choose either between their life or between working. And this is really a dangerous situation. And at the same time, we have a situation where we haven't yet reached the number of tests, the testing capability that we actually need, so as to get a really good idea of how many people in our community have this illness. So Ms. Thornton kind of alluded to this. We're saying a million. We have 1 million people who've tested positive with COVID-19 in the US. But there are some estimates that there might be 10 times more people. We haven't actually, as people have done some testing of serum looking for antibodies against this illness, where we've had people turned out have had the illness, but they never presented to hospital. So we don't know how widespread this illness is yet, and yet there's a lot of pressure to push towards getting back, opening businesses. It's interesting to me, like even in Georgia, where they opened businesses, that the businesses that they opened, I don't know, I could be wrong, but the businesses that would be more likely frequented by our community. And why is that? Why do that? So we have to be very careful not to fall into the traps that sometimes.
At the risk of falling into cliches and stereotypes, but you're bringing a point up that makes me suspicious, Dr. Kiragu. It's that there was a rush to open before the first of the month, and there is this national perception that a lot of money moves through the Black community through public assistance, or welfare, other systems, 1st and 15th. And so my natural suspicion tries to put 2 and 2 together. Are they opening all these businesses, rushing to open them so that they can capture the public assistance revenue stream that our country really depends on? Because our people line up, and the money we get, whatever way we get it, goes through our pockets and accounts so quickly, and probably a huge bulge going through on the 1st and 2nd of the month. But let me open up a little bit more and talk to Dr. Santano Rosario and Dr. Ainel Rosario. Dr. Santano, first of all, you are a new doctor working in ER in UCLA. Talk about what your experience is and has been in dealing with patients, community, with the COVID-19 pandemic underway.
Yeah, well, it's been, tough. I think we're getting a lot of people that are coming in that are, very sick and that need to care for us. I think something that's been really tough is kind of like the social family aspect of it, because, to keep, for public health standards, keep people safe, they don't allow visitors. For the pediatric units, you get 1 parent, and then for the adults, you get no visitors whatsoever. So you can have this in the middle of this like very scary pandemic, a loved one who has to go to the hospital, and you have to tell their family members that they can't be with them during, some of their most vulnerable times. So just, that alone has been really difficult for a lot of their patients and their families. It makes just any sort of hospital stay much more fearful. And then something I think that's, I think a little underspoken is a lot of the risks of people being too scared to go to the hospital. Something we've noticed is that we have a general consensus of the number of patients who come in with like acute emergencies, such as like appendicitis, cholecystitis, heart attacks, things of that nature. And we noticed that it's been down for the last few months with this pandemic. And just based off of statistics, like a lot of these people aren't showing up to the hospital because they're scared of, being sick, and that's resulting in them having a lot more complications, potentially dying at home, which is a whole, another issue in themselves. So that's something we've noticed, and we're trying to mitigate how to best, describe to people that although, yes, we want you to stay at home, we want you to, remain quarantined, stay safe. But at the same time, if you are sick and if you are feeling severely ill and you're having these symptoms that are concerning, that you feel like you need to go to the hospital, we don't want you to hold back. Like it's our job in the emergency department to take care of you and to assess you, and we'll, we do our best to, minimize those risks of exposure. But that being said, we still want to make sure that we're able to provide care for you. So it's very interesting having those two sides of it, having, this big rush of COVID patients, as well as a surprising downturn of a lot of these other illnesses.
How long have you been in the ER, Dr. Rosario?
So I'm in my first year of residency. So I've been in the ER just about a year now. I started in July. In our first year, they kind of send us all over. So we do a lot of time in the emergency department. We'll do a decent amount of time in our ICUs. So we get a lot of different exposure to a lot of the various stages of this COVID-19 outbreak. So we'll see them as they come in, teaching them about how to quarantine, how to protect themselves, how to protect their family, how to reintegrate themselves into the community, once their symptoms resolve, once their quarantine is ended. And then also when we see them in like the ICU or on the floor, how the disease can progress and how to best manage them as, patients for the long term.
And so in the year that you've been in your residency, is that the right word for it?
Yes, sir.
Okay. What's been the difference that you personally have noticed in the flow of people through the ER or through the hospital where you are? COVID-19 kind of came up 2 months ago to start with or so, and has sucked all of the air out of the universe, it seems. Everybody's focused on it, and that's why it's so important what you've just said, to remind people that the other things they had before still exist, right? Yes. And we still need to pay attention to them and respond to them and try to make sure we mitigate other complications that we may experience in the natural, movement of our, maturation or living or whatever it is. But what's been the difference from when you started, and how has the emergence of COVID-19 changed the way the world operates at the ER?
It's a big question. A lot of it is, I think, with how we practice. I think before we were very liberal in approaching patients, going into the rooms without really protecting ourselves. And I think now that we see how quickly this disease can spread and how many people it can affect, and the, large effect it has on the hospitals when, a physician gets sick or there's been an exposure to our nurses and our staff, that really, brings our emergency department in our hospital to kind of like a grinding halt. So I think a big change that we've noticed is the use of like the N95 mask and PPE to really protect ourselves and to protect our patients. We, down in the ER or down in the ICU, really anywhere in the hospital, you'll see multiple patients a day, and you're going from room to room. And if you're not really protecting yourself, you're potentially spreading, that disease to other people. So we've become, much more careful in how we operate as physicians within the hospital, making sure that we fully gown up, that we're keeping our patients safe, not only the ones that we're directly seeing, but the ones that will, be seen in the future as well. So that, I think hands down is the largest change. The donning and doffing of, all of your equipment takes a lot throughout your day, but I think it's like a very essential part that was previously overlooked.
You have to change your gowns at every patient? How does it work? What happens? Yeah,
so I guess the typical donning and doffing is that you'll put on your gown, you'll have your mask, we'll use goggles, or some people use face shields, sometimes to cover the hair, and then you'll have your gloves. And if it's like a standard patient who potentially has exposure, whether that's For us, we have a large homeless population, so anyone who's homeless is considered at risk. Anyone who has any respiratory symptoms, any GI symptoms, we're not finding things where it's like any like changes in smell and taste has been associated with COVID for our population. So we'll make sure we wear everything when we go in. We'll assess the patient. They usually have a disposable stethoscope, so we're not really using our own to make sure we're not spreading it through that to other patients. And then before we leave in the room, we have a large, doffing process where we take off our gloves, we sanitize, we take off our gown, whether it's disposable or reusable, where we send it to get washed. We'll wash our hands again, and then we take off our goggles, wash our goggles, and then wash our hands for full 20 seconds up to the elbows. And we do that with every patient we see. And then when we have airways or traumas where we have to be a little more diligent and potentially more invasive, we try to use the PAPR machine, which is like a negative pressure system. It's like a big almost like a helmet that you wear that helps prevent the cases of exposure. And we'll use that whenever we have to intubate or do any sort of invasive procedure where we're going to be close to their airway.
Fascinating. Thank you so much for taking us through that process. Dr. Ainel Rosario, I'm curious as to what kind of conversations there are between mom and son. I know that you guys, you're going to always be mom, number one.
Yeah.
But doctor, there's another relationship that you all have, and I'm sure that comes up in how you assess, your expectation that you each be safe, practice safely, and serve your professions, professionally, but safely at the same time. And as you're listening to Dr. Rosario, what are you thinking about in his presentation and his work and your advice, both as a physician, but also as a mom?
Well, I can tell you he thinks that I'm crazy sometimes.
That is true.
A typical mom thing. And, he can tell you that even before the CDC was saying wear a mask, I was telling him, you need to wear a mask. You need to wear a mask all the time because it makes sense. And it was reasonably frustrating to me in the beginning hear, well, it protects you from this, but it may not protect you from that and what it's doing. And so, he has always said, listen to the experts, Mom. So, but obviously mutual respect and adoration. But as we look at this whole panel and as I listen,
your camera, your light is fading in and out. So sometimes it's the backlight. So
I tried to move to an area in my office.
That's perfect right there. That's perfect.
So that the phone ringing was not a distraction.
Okay, no, that's perfect.
Is this better?
Yes.
Okay. So just saying though, as we, the purpose of this panel coming together is really to make sure and educate and inform in particular people who listen to this, so African-American or underserved populations about the COVID. This has been something that I want to preface and just say the obvious, and that is that nobody wants anybody to die. This is affecting everyone, irrespective of income, irrespective of skin color, political affiliation. This is absolutely not anything political. And so we want to keep political out of it. Even from a race standpoint, I think we need to approach the race part of it, in particular from the perspective of why. And some of our previous panels, we've talked about some of the whys, and that, why are African-American or Black and brown people being more effective? And so far from when we've looked at those numbers, what we're finding more often is, it may have started with that underlying access to care, access to understanding their health care, having a relationship with their doctor where, when right now the CDC, if you have symptoms, it says, call your primary doctor. Well, who do you call if you've not had a primary doctor and you're now afraid to go into the ER because you're thinking, if I go into the ER, then I might get it. So the big goal of, in our first panel discussion was really telling people, no, still go into the ER. You can still call 911. you're going to have all your heart attacks, all the other symptoms. You might have symptoms of COVID. And if you don't have a relationship already established with a primary care doctor, they may not want to start that relationship on the phone. So you still may have to use the ER. So I think the important thing is that we need to make sure that we get it out there to people that we're here to answer your questions, but please still go into the ER, connect with your primary doctor if you have one, but if you don't have one, then the ER is going to have to be where you go, and don't be afraid to do so. As far as businesses that are opening, certainly as a small business owner, I absolutely am feeling the pinch. I think that, and I know everybody's feeling the pinch, not just small business owners, but us maybe a little bit more, because you have other employees that are relying on you that you have to pay. But at the same time, we need to continue to practice that social distancing, social isolation. When you look at a country like Sweden that did not or has not socially isolated as yet, their rate of infection and deaths are the same as Italy, that has done all of those things. When we look at the businesses that are being open, they are, I would actually say that no, there are a lot of different people work in them. 6% of Minnesotans are Black and brown. So if you open a business, guess what? We're only 6%. So it's affecting all of the other races, if anything, even more. So as far as income and the beginning of the month, that goes for anybody on welfare or government assistance. So that is, again, spread across the board. So in particular for this panel, I want us to make sure and focus on making sure people are educated, and not have this be anything that implies that anything other than you weren't educated. We need you to be a better advocate for your health care. That's where we're at. It is truly, you need to figure out how to take control. It's like anything else, making money in the US. If you say, well, I'm this, and that, yep, you're going to absolutely find those situations, those people who are not going to allow you to move forward, but then you've got to figure out a way around it, because it truly can be an opportunity. And in this case with the COVID, we want you to take care, we want you to be aware of the opportunity, to be educated as to the fact that it does affect us. And it may affect us more because it might be that we're all in smaller quarters, or we're way too social and there are 10 people in one house. So let's focus on those things, and because those are the facts that transcend everything. And try to educate people, ask them to, call us, reach out to us. We're trying to support the food shelves where people go, and give them the same information. So when they're at the food shelves, they know, wear the mask, be aware of, it does affect Black and brown people.
Go ahead, Dr. Carago.
I want to add something to what the younger Dr. Rosarios had talked about. In addition to people not showing up to the emergency department for things that typically would take people to the ER, such as heart attacks, we've also, one of the concerns that we have as pediatricians has been people being scared to bring their children in for the routine vaccination. The American Academy of Pediatrics has set out some guidelines with regards to who should be going to get their immunizations, particularly those kids younger than 2. There are many visits that many organizations have made with regards to televisits, and there are many things that can be done in a televisit with your regular pediatrician or regular healthcare provider. But there are some things that do require you to go in. One of the other concerns that is there is that because of, and that a number of organizations are looking to try and change, is because of guidelines that have been set forth to protect people, a lot of so-called elective procedures, elective surgeries have been delayed. And, of course, if someone needs emergency surgery, they get it. But there are some, there is a push by a number of medical organizations now to try and, within the confines of being safe and providing good, if they have adequate PPE for all concerned and keeping patients safe, to begin to do some more procedures for patients who are suffering because they haven't had the ability to have the surgery.
I'm Al McFarland. This is Conversations with Al McFarland. We're talking to healthcare leaders, professionals, doctors, and nurses, a nurse. And if you have questions or comments, send them to us on Facebook, or I think you can maybe respond to us on YouTube, and we can share some of those questions or comments. If you like this programming, we invite you to do just that, to like it and to share it. We are going to be here every Friday with a panel of physicians and healthcare and community leaders talking about the impact of COVID-19, but ultimately we are taking advantage of the opportunity to create and spread knowledge in our community. As Dr. Inel Rosario has said, we're encouraging us to be more responsible, for us to take charge of our personal space, our bodies, our minds, our community, and to be proactive, know what we have to do to be safe, to practice living safely, and be responsible for doing that, be accountable to each other and to society. Dr. Rosario, or Harry, you had a question, you were going to say something, I think.
Yeah, well, a couple of things. Dr. Rosario touched on one when you were talking about the Sweden versus Italy in terms of the mitigating factors and non-self-isolation, things of that nature, because that's one of the conversations that's being had by many people in social media, people in my immediate family, talking about the fact that the social distancing isn't working because look at Sweden, but what a lot of people don't take into account is Sweden is a nation spread out over 10 million people. That's about roughly the population of New York City. So you don't take into account the instances of social distancing, population density, things of that nature. So that was one of the things that I wanted to touch on because there's a lot of it's not misinformation because the numbers are the numbers, but there's a lot of using the numbers to fit an agenda that I see. Another question that I had also was, I saw a video from an ER nurse in Washington, D.C. And this relates particularly to African-American patients that she's been seeing. So I wanted to know if you guys have been seeing this as well. She said that many of the Black people who come into the ER, the symptoms differ. She said a lot of the people that she sees don't have the fever, they don't have the cough, but they absolutely do have COVID-19. And so she's warning people to know that there's a difference in what we're being told as a general public of look for the fever, look for the cough and things of that nature. So are you seeing that in your patients as well?
So I'll go back to the Sweden thing. So you're right, the numbers are the numbers. So I give Sweden as an example, and that you can compare it to the US, where when you look at the amount of patients that have been infected and the percentage wise, when you compare New York or any densely populated city, you're going to see that be a lot more compared to an area that is more spread out. So Sweden is a perfect example because when you have a densely populated city, you're going to have a much higher spread. When you have an African-American household that is with 5 people in and they share a bedroom, you're going to have a much more significant spread. When you have an African-American household and they're 5 bedrooms and everybody's got their own bedroom, even if one person gets sick, you're going to see fewer people within that household come down and get sick. And that goes across the board. If there is more concentration of people, you're going to get more people sick. And even going back to Nurse Thornton and her saying, you know, I can go outside and, you know, walk my dog at this time in the morning or this time in the evening. And as opposed to wearing a mask, I cross the street. Well, if you're in New York, no matter what time you go out, you're going to run into people and you could be crossing the street zigzagging the whole time. But because Minnesota is less densely populated. So for someone in New York, I would say you've got to wear a mask all the time. Quite frankly, even for someone in Minnesota, I would say you've got to wear a mask all the time, because if you truly look at the aerosolation of the virus, 6 feet it would be considered the minimum. You know, I don't think anybody wants to scare anyone, but you would say wear a mask all the time when you are outside of the confines of your yard. As far as, so that from a Sweden standpoint, it is just an example that says when you're concentrated, Sweden has what, about 8-9 million people. Italy has 63 or something like that million people. So definitely, you know, that gives you the density difference, and you can basically stamp that into the US, and you see our concentrated areas are the areas that more people are getting it, more people are dying from it. When you look at, actually the second part of your response was more related to
there's a nurse in DC who shared a video, and she was saying that a lot of the Black patients who present differently than other
symptoms,
patients.
right? Yeah. And so from a symptom standpoint, that's not just in the African American community, that is across the board. When you think of how COVID first started, it was, oh, it's a China problem, it won't make it over here. Oh, well, let's close our borders. Well, it's not going to be a Minnesota problem. In fact, I think one of these shows we had, someone was saying, why is, maybe Harry, you asked, why is it that Wisconsin had a much higher response rate or death rate than Minnesota? And if you recall, my response was, let's wait till those numbers play out, because it's early in the game. And that really is, you know, can be just a matter of timing. And unfortunately, not that we want anybody to die, but hey, we don't want Minnesotans to die because it's closer to home. You've seen that now Minnesota is ahead of Wisconsin in the number of deaths, even though Wisconsin has had more confirmed tested patients. So as far as the disease itself, initially we thought, oh, more elderly people. In fact, last night on the news, one of the doctors somewhat intentionally wasn't as aggressive in PPP, wanting to just get the illness over and be able to take care of patients, and found that, wow, he was really, really sick, and it affected him way more. We're now finding that not just fever, shortness of breath, then it showed up that, well, you can have GI symptoms. Well, you can actually have symptoms of a heart attack or a blood clot in your leg where you're now more short of breath with no fevers. So over the course of this, and younger people dying, we've had a 5-year-old, a 5-month-old, and I'm sure other kids that just haven't made the news that have passed away from an illness that we thought was mostly nursing home, mostly elderly people. So the disease and how it presents has absolutely been evolving. The amount of cardiac damage and organ damage that they've seen were not noticeable or not reported anyway in the beginning. So we are learning as we go, and we're modifying as we go. Just like in the beginning, the CDC held off on saying wear a mask. Now finally everybody's saying wear a mask and wear a mask all the time, because we've not seen the slowdown in the disease with just social distancing. So it is a learning curve, and it is changing. And hopefully with social distancing, so trying to stay 6 feet apart or more, not going out unless you really have to, being good with hand washing. I've always added the nose washing. Last time I also mentioned, please also protect your pets. When they come in from your walk, you know what, you have to wipe their paws, because they were on the ground. Their, you know, little feet were on the ground, and then they're going to lick you, or their noses were on the ground. So wipe their paws, their fur, their nose, so that all of those, just like you're washing your hands, have less of the bacteria, even if, or the virus, even if they aren't getting sick, has less chance of getting you sick. So doing those social things is going to help us kind of cut down on the number of cases of the coronavirus and the lethality of it, because we're finding more and more younger people are not doing well.
Adrienne Thornton, jump in here again. And also Dr. Kiragu, I'm wondering, and this is carrying the theme of cultural populations forward. We've talked in the past about Milwaukee and New Orleans and St. Louis and Chicago. What about internationally? Minnesota is a diverse community, lots of Caribbean, Somali, West African populations here. And I don't know if any of the data we have breaks out the impact of coronavirus on those segments of the Black community. But I wonder about the diaspora in general, our people in the Caribbean, but also our populations in continental Africa. What's been and is becoming our experience there. Do either of you have any ideas or suggestions or thoughts about that? Adrienne, go to you first.
So I want to point everyone in the direction of a wonderful map. I literally look at this map probably 10 times a day. It is one that Johns Hopkins maintains, and it is a world view of all the coronavirus in the world. Mm-hmm. And I look at that map often because I do want to see what's going on in other countries. And I'm always looking at Africa. And the last time I looked at it, it really looked like the whole continent was just outlined in coronavirus. And then the more you got to the middle of the continent, there was some, but not a lot. And so I wondered about that. And I've had conversations with my director and with some other people. And it may be that the reporting capabilities in those countries in that part of the continent are not as good as what we see in other countries or in the US. And so I can't say for certain that, because the reason why I started looking at it is because, of course, you know, people would say, oh, Black people don't get coronavirus. We don't get it. Look at Africa. There's none in Africa. And that's not true. There's some there, we just might not be able to hear about it because if they don't have the infrastructure in their countries to report it and do surveillance and maintain, you know, all those surveillance systems, we may not know about it. Doesn't mean it's not there. It's just that we don't know about it. And so the perimeters of the continent are definitely being impacted. The middle part of the continent, still not sure. I continue to watch that map to see if at some point we'll get more reporting of cases in that part of the continent.
So, and just to kind of add on to what Ms. Thornton is saying, the African Union, so just talking specifically about Africa. So the African Union, along with CDC Africa, also have a wonderful map that gives an idea about how COVID-19 has impacted the continent. So currently, across the whole of Africa, there are about 39,018 cases that are reported. There are some countries that are hit more than others, and there are some countries actually that have been pointed as examples as they try and figure out why is it that a country like Madagascar, which is an island off the east coast of Africa, has not had any COVID deaths. They've had a few cases, but no deaths. What's going on in that community? There are also other countries across in Africa, so like Senegal, which has instituted essentially looking to do universal testing, antibody testing for everyone. They're actually featured in the news. They have a $1 a test that costs $1, and they're testing everyone for antibodies to COVID. And so there are some examples across the continent of wonderful work that people are doing, not only to prepare for the potential surge that people are worried about, and especially given that in many countries across the continent, the resources are limited. We talk about the number of ventilators here in the US, and we're worried about running out of ventilators, but you can imagine there are some countries in Africa where the number of ventilators is really and so you have the increased rates of poverty. So the difficulties with telling people who live in, say, a slum, to talking about social distancing, or stay at home, don't go to work, when you're really living from hand to mouth on a daily basis. So, but then what you've seen across many countries is work between the governments, local community organizations, different private entities coming together to help in terms of providing masks, PPE, hand sanitizer, all these different things that people might need and then of course a program of education across the continent. And then trying to expand testing. Testing is an issue as well. And as Ms. Thornton had alluded to, perhaps once testing expands, you'll begin to see the numbers are higher. But my hope and prayer, especially for parts of the world where resources are limited, that we will not see the kind of surge that we are worried about in places where there's more equipment and more availability of resources to help take care of people. So, but there's a lot of good things happening too.
We've come to the end of our hour. The time goes so fast. We thank all of you. I'm going to ask Dr. Rosario and Dr. Rosario to close the program. First with Dr. Rosario from UCLA, talking about, from his experience as a ER doc, what you could encourage our viewers, listeners, our community to do to take this threat seriously and to be preventive and to protect their health and to make sure that they don't endanger other people. That's number one. And then I wanted to ask Dr. Inel Rosario to close out with an idea of what we should be talking about maybe next week's program, things that if you want people to respond to you, how they can reach you or reach me so that we can broaden this conversation. It's an important conversation. So first, Dr. Santano Rosario.
So I think it's really important to continue with the quarantining and protecting yourself, wearing the mask, washing your hands, especially as states start to open up. I think it's like a very delicate time as we try to start reintegrating ourselves back into our communities, and it just puts everyone at a much higher risk of having this infection. So I think now more than ever, it's extremely important to continue covering your mask. If you are feeling sick, come to the hospital. I think that's something that the ED community can't stress enough. We want to make sure that give us a chance to be able to take care of you, and maintain the social distancing, maintain from 6 feet. I think it's important that just because things are slowly starting to open up, that doesn't mean that you can kind of just relax and start, not wearing your mask and seeing people and kind of putting all those cautions to the wind. I think it's going to be a very tense next few weeks, I think, as things start to open up and seeing how different states do. And I would just highly, highly encourage everyone to just continue wearing the mask, continue washing your hands, continue disinfecting all your surfaces. And if you feel sick, please let us come try to help you.
Great. Dr. Inel Rosario, thank you so much for organizing these forums. Final words for today, but also what do you have in mind for next week and weeks ahead? What kinds of professionals and physicians are we reaching out to bring to this conversation table?
So in the future, we want to, again, bring back some of the dentists and as well some of the people in the community that are doing great work as far as making masks to try to keep everyone safe. We'll see if we can get someone from the Department of Health, even one of the local pastors, to kind of see how they're reaching out to their community, because your spirituality is so important to help you get through being in quarantine, not having a job, income, the government money. So I'm going to reach out to one of the local pastors and try to have some of them on, so that they can be an inspiration to their parishioners even in these times, outside of what they're doing on Sunday mornings or during the services. So that's what I have planned for that. I'd like to tag on to what my son, the other Dr. Rosario, has said, and that is with testing. And I do think that, yes, let's go ahead and test people. But my fear for the universal or more increased testing is that people will say, well, I got tested and I'm negative, so I don't have to wear a mask, or I don't have to social distance. And so I want to make sure that people know that for the start, even when you have the antibodies, they're finding that maybe you can get it again. Maybe it may be higher. So while testing will maybe put in better perspective the relative number of deaths per population, I think that is all it does. So we still need to, whether you are tested and you have antibodies or not, or you're positive or not, please still continue with the social isolation and wearing the PPE until we get a vaccine. I think until we get a vaccine, or there are very few people in the hospital, no matter your test status, you should still wear those or take those protective measures. It will improve us being able to do surgeries on people. And so that's where I think the test is really has the biggest impact, is how we go about doing elective surgeries and protecting the staff. But yes, test, but do not change what you're doing.
Thank you all so very much. And thank you for listening and watching on Facebook Live and on YouTube. Thanks to Kelvin Curia for engineering, and for Harry Colbert Jr. for co-hosting with me today. I'm Al McFarland. This has been Conversations with Al McFarland. This series we're calling Serving the Underserved. We'll be here again next Friday at noon, talking to leaders and professionals in the health industry, in the medical field, and in community service. We hope to see you next week. Thank you all so much. Thanks, team. Thank you.
Perfect. Thank you.
Thank you.
Great.